Good afternoon. Thank you for joining us this afternoon. PAME, we're very glad to have you here. Partners Against Mortality and Epilepsy is a coalition of organizations working together to convene, educate, and inspire all stakeholders, from the bereaved to those living with epilepsy, to healthcare professionals, advocates, clinical and basic scientists, and death investigators to promote understanding and drive prevention of epilepsy-related mortality. As we get started today, I just wanted to share a few housekeeping items. First, we hope that you'll share your questions in the question and answer feature. This will help our moderator as he goes through and lines up the questions at the end of the webinar. And we hope that you will use the chat feature to interact with each other throughout the webinar. If you've got any specific questions about your own individual story, we may not be able to answer them on the webinar, but then also know that a recording of today's webinar will be made available immediately this afternoon, and you will receive a link to it tomorrow. One last thing before I introduce our moderator is to recognize UCB. Because of their generous support, we are able to provide this education to you today. So now I'd like to hand it over to Tom Stanton, who is the president of the Danny Didd Foundation, who will be our moderator.
Thanks so much, Anne. And thanks everybody for tuning in, spending some time with us today. We have a really excellent panel that I'm excited to introduce on a topic that is really important to our epilepsy community and fast moving. So we're lucky to have quite a few experts on the topic with us today. Everybody tuning in probably realizes that epilepsy is a common and very serious brain disorder. And unfortunately, it can be life-threatening. There's many different causes of mortality in epilepsy, SUDEP being one of them. And the purpose of this webinar is to really highlight state policy interventions that can help prevent some of these deaths and also arm advocates with the necessary tools to make change in your communities. And this subject is important and personal to me because I lost my nephew Danny to SUDEP, and his family was never informed about that risk prior to his passing. So we've been working on this issue and awareness for this issue for the last 15 years now. So very grateful to have this as a point of focus with PAME. In kicking this webinar off, we want to first start by thanking the many families and advocates who have worked tirelessly at the state level to share personal stories and who work with state lawmakers to advance solutions that protect kids with epilepsy. We're extremely grateful for all the work that's been done to date. There have been several different approaches taken over the years, some more successful than others. Some approaches have even caused controversy, such as laws that mandate SUDEP disclosure by healthcare providers. So we at PAME saw an opportunity to bring various stakeholders together to learn from what's been done and to find some common ground so that we can organize around vetted solutions and hopefully more quickly affect change, knowing that it is stronger to speak with one voice. So today we're going to hear from 3 different speakers, and then we'll open the conversation up for questions. First, we'll hear from Hannah Witten, who is a woman who lost her brother and has been working hard to advance SUDEP education in Oklahoma. Hannah is an attorney at the Witten Burridge Law Firm. Her older brother, Dylan, was diagnosed with epilepsy when he was just 2, and sadly, he passed away from SUDEP in August of 2017. Hannah is a board member of the Isaiah Stone Foundation, extremely engaged with Cure Epilepsy and their development and communications committees, and she's a member of the PAME Governance Committee. She's also the executive producer of the documentary, The Curse of the Stigma. We're also going to hear from 2 others. Dr. Laura Lubbers is the Chief Scientific Officer of Cure Epilepsy, and she's going to describe the problem of epilepsy-related mortality and barriers to research and prevention. Dr. Lubber's sister Ellen suffered from intractable epilepsy from an early age, and her mother was diagnosed later in life. So the impact of her personal story definitely fuels her passion to find better healthcare solutions for people with epilepsy. And finally, we'll hear from Katie Collins, who is an expert on crafting legislative solutions. She will share about PAME's work to assess the state legislative landscape and efforts to identify policy solutions that can be championed by advocates at the state level. Katie is with G2G Consulting, and she has over a dozen years of experience in Washington, D.C., working with federal agencies, the executive branch, and many nonprofit organizations. So with that, Hannah Witten.
Hello, everyone. My name is Hannah, and I appreciate everyone for tuning in today. I'd like to thank Tom for the very kind introduction and everything he does for this community. I'd also love to thank Gardner. I'd love to thank Laura, Katie, and Anne. Thank you guys so much for asking me to be here today. So I'm going to focus on Oklahoma specifically because that's where I live. That's where my brother grew up and where he died. I don't know how to do the next slide. So Dylan's battle against epilepsy. My brother started seizing at 2 years old. Doctors first told my parents he was suffering from night terrors, and obviously that later became an epilepsy diagnosis. My brother tried many things to curb his epilepsy. Next slide. So Dylan's battle against epilepsy, as you can see in the picture on this slide, this is after we attempted a brain surgery, but we tried various different things to curb his epilepsy. Oh, he was never able to achieve seizure control through medications. He spent his life switching on and off a cocktail of anti-seizure medications, which had varying levels of efficacy and debilitating side effects. He had a vagus nerve stimulator implanted in his chest, which did not end up curbing his seizures. And we attempted a brain surgery wherein after they removed portions of his brain or portions of his skull, they triggered a seizure and were able to see what portions of his brain lit up. It was determined at that point that his epilepsy was too widespread to operate. My brother died at just 25 years old. My big brother and best friend passed away of sudden unexpected death in epilepsy, or SUDEP. It has been 7 years since I held his hand, I heard his laugh, or saw his smile. I will miss him every day of my life. Despite seeing epilepsy healthcare providers for over 20 years across the country, not a single person ever warned us of SUDEP, the risk factors, or how to prevent sudden death in epilepsy. But it's so important to discuss these risk factors. So the SUDEP risk factors, despite Dylan having every single risk factor, no one informed us. I'm going to go through the mainly recognized risk factors. So the main one is tonic-clonic seizures, or movement seizures. Dylan suffered from those. He had early onset epilepsy. He was a young adult when he died of SUDEP at 25. He had epilepsy for over 20 years. He was never able to achieve seizure control through medication. He had nighttime seizures. And one of the risk factors is not taking our medications regularly, but I will say there's a certain portion of the patient population that will max out of epilepsy drugs, and having to continuously switch on and off these anti-seizure drugs does have a similar effect as not taking epilepsy as prescribed, and that's really the uncontrolled epilepsy community faces that. But there's hope. It's not just the risk factors. There are ways to mitigate risk. In my view, it's extremely important that we educate people living with epilepsy. Every state has informed consent laws. It's my view that embedded in those informed consent laws, doctors should be educating about SUDEP. So the ways to mitigate risk include nighttime monitoring, whether that is through epilepsy devices, and you can learn more about that through Danny Did, or having a family member sleep with you, or even a seizure dog. Co-sleeping does have some pretty significant impacts, and getting enough sleep, avoiding known seizure triggers. People living with epilepsy already live with great fears of death. They live with the fear of drowning, of hitting their head. And because this community has to stay vigilant in terms of preventing death, it doesn't make sense not to educate them about the #1 cause of death for people with uncontrolled epilepsy, which is SUDEP. So in my view, there's two paths forward. I'm so grateful to know everyone on this call, and they really inspired me to see how I could impact unique change in Oklahoma. As Tom mentioned, there is a bill in New York, and I heard many friends and colleagues in this space kind of discuss the negative reaction to the mandatory disclosure implemented in the New York bill. So, I like to learn from those things and also try to see what else we can do. So, in the 7 years since Dylan has died in Oklahoma, there is not a single bit of change in law or policy in this state for people living with epilepsy. I'm actively trying to change that. I'm working to pass Dylan's Law in Oklahoma, which mandates SUDEP reporting from medical examiners. It mandates autopsies in certain SUDEP situations. It requires insurance companies to cover epilepsy devices and has other aspects intended to improve the lives of Oklahomans living with epilepsy. If you want to see this bill, I'm happy to send it around and share it, but that's really not the main point of my presentation today. The main point in my presentation is the billing code. So the purpose is similar to the New York bill. The New York bill mandates every doctor has to. This is more so the carrot instead of the stick. I was talking with doctor groups locally about how we could encourage physicians to discuss SUDEP more in their offices, and I heard overwhelmingly a billing code. I also had a mentor involved in the ESPER code, the addiction billing code, and she shared some really awesome advice about this. So I've approached my healthcare authority on this issue, and I'm working towards making Oklahoma the first state to implement a SUDEP educational billing code, which would pay doctors to educate patients about SUDEP. I'm working with the Oklahoma Healthcare Authority on this project, and they were kind enough to share some preliminary data with me that I am sharing with you guys today. So this is the first aspect of the billing code analysis compiled by my state's health department. And obviously everyone on this call knows that these deaths are vastly underreported. So this is just the information they have available to them, but you can bet your bottom dollar that these are lower figures than truly than the true figures would show. But this shows the primary diagnosis, the members served within Sooner Care. Each state has their own level of state healthcare issues, and I don't work for the state, so this has been somewhat of a new experience in terms of bureaucracy, but I'm happy to share all these resources offline as well. But this first slide really shows the members served within our healthcare community and all of that. And so the next slide kind of leads into the code analysis and the budget estimate. This is the stuff I find particularly interesting as we're getting up to go. So we have like 2 sets of codes that we're circulating with physicians, but also discussing the cost of this. So if you're a family watching this and you're interested in going to your state's healthcare department and advocating to implement a Medicaid billing code, you will likely face similar bureaucracy issues. The biggest one I'm facing is cost. So as you'll see on the budget estimate at the bottom, they estimate that it would cost around $260,000 to implement this billing code. In my view, that's almost nothing compared to the impact it would have in the people living with epilepsy. So that was really exciting to me, the cost of this. And they have found 6 to 7 offices they would implement this code in, at least in the first year. There's no point in turning on a code if you're not also doing simultaneous education. So while we are working on building out the code, implementing the code into our current Medicaid system, we are also simultaneously educating physician groups on how to use that code, what education would look like. And so, it's a kind of a 2-part system. 1 is actually developing the code. 2 is educating the community on how best to use the code and implement it. So here's sort of my 2 buckets for everyone. I kind of put into challenges and good news. So, as I kind of touched on, there's some bureaucracy involved in this process. in my view, the biggest challenge I have faced is my state budget. So other disease groups are advocating for state Medicaid dollars. Epilepsy is not the only group that is looking for a billing code. And so the Oklahoma budget is, it's underfunded, it's competitive, and I'm advocating against other patient groups in this space. I have learned that I needed the help of a lobbyist. So we have hired a lobbyist to ensure dollars are specifically earmarked for this billing code in the state's appropriation bill. So I am actively working on getting that $260,000 specifically earmarked by the Oklahoma legislature, wherein they could not use those funds for anything else, and the code would be turned on automatically. The good news, I will say, is that there is a ton of appetite and excitement for this. I was just really surprised when talking with physician groups. I have yet to meet a doctor in Oklahoma that told me they wouldn't use this, they don't like it. Of course, there are suggestions on what the code should implement or what it shouldn't implement, and I'm absolutely letting physicians lead that discussion in this state. I think physician buy-in in this is extremely important. They're the most important thought leaders on this issue, and I'm extremely hopeful at the coordination of bereaved families and doctors in Oklahoma on this issue. So anyway, if anyone wants to talk to me about, either the legislation or the code, I'm always happy to chat. I'm going to continue working on this issue. I'll never stop doing this until the day I die. I'm happy to circulate any of the information sent to me by my state's healthcare authority to ensure doctors are able to be involved in this from the very, drafting phase. I also would be interested, if you're on this call and you want to bring this information to your state's Medicaid director, I would love to know, like, what's the estimated cost? Like, what barriers are you facing? Happy to share information and kind of see if I can help you move the needle, but I'm especially interested to see what drafted codes. So anyway, if anybody gets that far in this work, please call me or email me. I would love to compare billing codes or legislation or any of it. I practice law for a living, but this is my passion, and I'm deeply hopeful that we are able to move the needle in the state and in the country. So thank you all for taking the time.
Thanks so much, Hannah. And your passion definitely comes through. And I love how multifaceted your approach is in Oklahoma. Exciting proposal, and hopefully it moves forward. I have a feeling it will. Okay. Next, our next speaker is Dr. Laura Lubbers, who's going to talk about barriers to research and prevention. So welcome, Dr. Lubbers.
Thank you all, and thank you to Hannah for sharing your family's story. That is not easy to talk about. I know that personally, and so I want to thank you for doing that and for sharing the passion that you have and all of the movement you created in such a short time. I remember meeting Dylan in the spring of 2017, and he was such a bright light, such a wonderful person. He's definitely missed by many, including myself. He keeps me moving forward. His memory keeps me moving forward, as does the memory and the knowledge of Danny. It's so important to share these stories. So thank you. I know many of those who are on this webinar already know these stories well. Some, a handful may not, and hopefully this webinar will live on, and others will come along and see it and may not be aware of these issues. And so I do want to speak a bit about the lack of information. We know that many people are not informed about epilepsy-related death. And this is a common theme for families who learn much too late about the risks associated with epilepsy. So I want to start by sharing what we do know about epilepsy-related deaths, and particularly SUDEP, and especially the risk factors that contribute to SUDEP. Hannah's already done an amazing job of putting that into perspective, but it never hurts to review. And then what we can do to reduce mortality. And then Katie will take it from there. Next slide. So I know many of you already know this, and I recognize that the facts and stats are always difficult to review, but it's important to know that it is estimated that people with epilepsy are 3 times at greater risk of dying early than the general population. We know that these estimates are dated. Look at that date, 2014. But these are still the statistics we're using and that we have to rely on. So that's something we need to change. Common causes of death include injuries or accidents, hitting one's head, status epilepticus or SE, drowning, and suicide. But again, the leading cause is SUDEP, as experienced by the families of Tom and Hannah. I'm sure many of you already know this, but SUDEP is more common than the widely known SIDS, or sudden infant death syndrome, and yet we don't talk about it the way new parents don't learn about SUDEP the way they learn about SIDS. So currently, our ability to capture reliable data about the causes of epilepsy-related death, including SUDEP, is limited to a small number of states and cities in the US. And certainly this could be improved by more expanded surveillance programs within the US that could help us better understand the extent of the problem, and then identify ways to fix it. As Hannah has already mentioned, we know that these numbers are probably very low compared to reality. We're hearing all the time about somebody that passed away due to SUDEP. We need to really understand the magnitude of the problem. But how is SUDEP defined? What is it? SUDEP is defined as the sudden, unexpected, non-traumatic death of an otherwise healthy person with epilepsy without evidence of a structural or toxicological cause of death. As Hannah alluded, there are different levels of certainty, including definite SUDEP, probable, and possible. And that can be ascribed, it's depending on the amount of information that is available when the person dies. But as many of you on this webinar know, these deaths are often unwitnessed, so an autopsy is often required to definitively conclude SUDEP as the cause, and that's not always possible. Next slide. So SUDEP is a public health burden because, as in the case of Dylan, it often occurs in people who are between the ages of 20 and 40 years of age. So the potential productive life years lost is huge compared to many other diseases that are more common but affect older adults. When years of potential life lost are considered for these neurological conditions shown on this slide, and many of you know what these are, ALS and multiple sclerosis, Alzheimer's disease, Parkinson's, SUDEP is second only to stroke in the number of years of life lost. 1 in 1,000 people with epilepsy, whether a child or adult, will die each year of SUDEP. Those with uncontrolled epilepsy are at even greater risk. And when we factor in the number of people with epilepsy in the US being at least 3.4 million people, this quickly reaches thousands of people lost every year to SUDEP. While Hannah's already talked about some of these risk factors, there are a number of publications that have provided information, and we'll review some of this, that they've assessed various characteristics of people who died of SUDEP. And we know that there are identifiable risk factors that are associated with it, as shown on the table from one of these publications. The most significant is the occurrence of generalized tonic-clonic seizures, or GTCs, which have been previously referred to as grand mal seizures. You can see in the table with the red asterisk at the very top that having more than 3 generalized tonic-clonic seizures per year puts somebody at significant risk of SUDEP. That doesn't mean that other seizure types also aren't important to understand. Certainly, other seizure types are associated with SUDEP, as seen in the line right below that. Another asterisk, another item that is highlighted is not having anti-epileptic drugs or anti-seizure medications. So that's certainly a risk factor, not taking anti-seizure medications on a regular basis, or right below that, having multiple anti-seizure medications. These individuals are also at greater risk, and this suggests that these SUDEPs are occurring in people who have hard to control epilepsy. Next slide. So in addition, having generalized tonic-clonic seizures at night increases the risk of SUDEP. We know that many people who succumb to SUDEP are found in the morning by loved ones often in the prone position, so laying on their stomachs. Sleeping alone or living alone is also a significant risk factor. And you can see how the risk goes up with these different predictors. But here you can also start, can you go back a little bit? You can also start to see factors that are modifiable. Using nighttime monitors, as Hannah suggested, and supporting and doing everything possible to reduce the occurrence of seizures. A recent study by Dr. Sandy Lamb at Lurie Children's Hospital in Chicago demonstrated that surgery as an intervention for epilepsy can help reduce the risk of mortality in children. So exploring all options for seizure control with care providers is of critical importance. A recent report also demonstrated that improved communication about risk factors can help parents understand the importance of using best practices when managing their child's epilepsy. These include giving medications in a very consistent way, monitoring activities of the child, and having seizure action plans. Instead of, people often are concerned that if this information is given to parents, they will cause worry, anxiety. But in fact, giving this information, a recent study showed that giving this information does not increase anxiety or depression about the potential for SUDEP, but it's actually empowering to create positive change. So why doesn't this happen? We know in practice that there's inconsistency in SUDEP counseling that doctors provide compared to what's recommended in clinical guidelines. Another recent report indicated that one of the primary reasons for this lack of communication is due to a lack of knowledge on the part of healthcare providers about SUDEP. And this is something we also need to change. And I think something that the code that Hannah is attempting to bring forward could help with. Next slide. Well, I just want to quickly summarize that we know that premature mortality is common in epilepsy. It's not rare. It occurs at all ages. It occurs for multiple causes, and many of those have been identified, including risk factors for SUDEP, and nobody is immune. But many of the causes are potentially preventable. So education about the risks associated with epilepsy is key. As I mentioned, many families, and as many of you know, these families are not educated about mortality associated with epilepsy and SUDEP. We understand that this is a difficult topic for everyone, including healthcare providers, who also need support in having these conversations. Some states, as has already been mentioned, have tried to do this with mixed results, and hopefully efforts like the one that Hannah is bringing forward and that Katie will share with you will help with this.
Great. Thank you, Dr. Lubbers. All really critical information, and we are going to close up with our final speaker, Katie Collins. So Katie, I'll turn it over to you.
Thanks, Tom, and thanks to Hannah and Laura for getting us started in such a compelling way. I joined this advocacy team, this legislative team, to talk about what can we do on the policy side? How can we make a difference using policy to reduce deaths related to epilepsy? And how can we equip advocates with the tools they need to make a difference in their state? And we want to do that with policy recommendations that are backed by the broad stakeholder community, backed by experts. And so the legislative team has been working for the better part of a year now, essentially to say if we could arm advocates in states across the country with policy change that they could take to their lawmakers who want to do something for SUDEP and for epilepsy-related mortality, what would that look like? How could we educate lawmakers both about SUDEP and other related mortalities, and what kind of policies that they could put in place to really see broad-based nationwide change? We can go to the next slide and talk about how did we get there. And we really started by looking at what's already been done across the different states. Hannah, when she was introducing her work in Oklahoma, talked about New York. New York is well known for having a mandated disclosure law. So for essentially saying that physicians had to tell their patients about their SUDEP risk. And what we really found out was that that was not something that was going over well, and not something that we were really seeing data to show that it was making a difference, that physicians were struggling to know how to have that conversations, with what patients to have that conversation, and that they didn't have the resources to support them to have that conversation in a productive and empowering way. Beyond mandates, other things that we saw across states that were interested in legislating around SUDEP were education and awareness, whether that was the general public, whether that was physicians, whether that was patients or MEs or death investigators. More surveillance and data, so essentially more reporting, so that we have deaths classified in the correct way and that it's being reported. So all that data is counting to show the prevalence and burden of SUDEP, and more disclosure so that patients know their risks and how to mitigate them. So this was the landscape that we saw across the United States, via laws that look, excuse me, I'm getting over pneumonia, so I don't sound so great. My apologies. Some, in states where things were working well, some in states where maybe they weren't seeing the data to support the work that they were doing. So let's go to the next slide. So what we really wanted to do was put together a policy proposal, kind of a choose your own solution. We listed several that could be used comprehensively as one, package of legislative reform, or that you could pick multiple things. And the places that we really came down where we thought that policies would make a difference were on state health department resources, empowering families and parents and patients and physicians with evidence-based information on SUDEP and other epilepsy-related mortalities. So making sure that states with the expertise that exists at the health department are getting information out that educates on risk factors, that provides contact info for support services, and that's easily accessible online, as well as hopefully being distributed in a doctor's office. As Hannah spoke a little bit about her Oklahoma law, making sure that the medical examiner or the coroner's association, depending on the procedures in that state, are ensuring that all death investigation professionals are educated on updated professional guidance so that epilepsy-related deaths are correctly identified and then reported so that data is accurate. Next slide. Awareness. One of the things that was really important is how do we get out the word about this? And we kept coming back to the Safe Sleep campaign or the Back to Sleep campaign. I was just coming back from maternity leave when I started this work, and had the Safe Sleep thing pounded into me everywhere I went. How do we do that? And I realize it's not quite the same thing, but how do we do that for epilepsy? And you can see, just a couple of promotional materials that go with the NIH and the CDC's Safe Sleep campaign. And then you can see a chart on the left there that really shows the data to support that with awareness and parents making safe sleep changes, really how many lives were saved. So looking at a public awareness campaign through a state health department on SUDEP and other mortality risks, as well as mitigation strategies so that we can expand awareness and educate about epilepsy and the mortality risks that come with an epilepsy diagnosis. And finally, looking at coverage. And I think We're really excited to hear a little bit more from Hannah in a moment about her success with coverage in Oklahoma. Because really providing coverage for post-diagnosis epilepsy education and risk counseling has the potential to make a huge difference, so that when a patient is diagnosed with epilepsy, they have that time, whether it's with a doctor, whether it's with a nurse, to be educated that mortality is a risk that comes with an epilepsy diagnosis. And here are risk mitigation strategies. And we suggest in our policy proposal a couple of different ways to do that. Whether it's dealing directly with a managed care contract or a case management fee, or even integrating it into, there's often patient-centered medical home incentive programs. So whichever way a state found most palatable to provide coverage, that this would have a huge, huge impact. Let's go to the next slide. And so what we're going to be excited to share with everyone, excuse me, I'm going to take a sip of water real quick, is an advocacy toolkit. And so we'll be sharing this with you, but what you'll see is a cover letter to the advocate, essentially sharing what's there, a white paper or a short backgrounder on epilepsy-related mortality. What is it? How prevalent is it? Why does it matter? And why are we coming to you, our state legislator or our policymaker, about this issue? A one-page, I call it a slick sheet, but a one-pager that really breaks down the statistics in a digestible way on why this is important, and then the policy proposal menu that I just went over. Let's go to the last slide. And I think what we're so excited about is to get this out there and to help advocates who are interested in utilizing this policy toolkit in their states. So my email is here. You can reach out to me or to anybody on this webinar if you're interested in getting involved in state policy work and you have questions with specifics about the toolkit. You have questions about what working with your state legislators might look like. We're here, I think, to assist whoever might need some help.
Thank you, Katie.
Of course.
Excellent information. And I really appreciate kind of the scope of recommendations. And I know, in talking about and working on the toolkit, just the idea that there are different ways to come at this. And I think having some of those laid out for our community can be really helpful and beneficial. So thank you for talking through that, playing hurt today. So we appreciate you doing it.
I'm just sorry about all the coughing. Thank you.
That's okay. So I did want to introduce one other person because we're going to take some questions. And Gardner Lapham is a friend and co-founder of PAME, who may jump in here. So Gardner, welcome to the conversation.
Thanks, Tom.
But I'll jump in because we do have quite a few. So one question, and I'll maybe start with Hannah on this one, was just where do I start in my own state? What are some of the first steps that can be taken? If you want to maybe share a little bit of your experience from Oklahoma on that front.
Sure. Well, the first thing I did was start engaging local leaders. I will say, I came into this with almost no experience at the state level, and that was, it's just been a learning process, I would say. So the health department is very disconnected from a lot of the politicians. That's sort of two separate fronts that you need to attack almost at the same time. What I will say, though, is that there's benefits to approaching both. They have a long-lasting relationship. It's my understanding that each state's health department runs from a state health appropriations bill. That bill is separate and apart from any other appropriations bill. So you approach your healthcare department and they say you want an educational code for SUDEP. Well, we need to identify how many offices in the state we would implement that in, and then how many physicians are in that office. And then you kind of break down a cost. And at that point, you have a number from your healthcare authority to take to the legislators to say, hey, The healthcare authority can't lobby for themselves. They can't ask for $260,000 to implement a billing code. It's improper and you can't do it. So that's where we come in as advocates, as people plugged into the epilepsy community. We come in and we start advocating our local legislators. Hey, I know how much it's going to cost. I know how many offices it'll be implemented in. I know exactly the appetite for this in my state. I've talked to physician groups. And so in my experience, that's how it's been done. And you can't really do one without doing the other.
Great. Very good. Thank you, Hannah. Okay, there's another question that came through, which was, is there a way to improve our understanding of epilepsy-related mortality in the US? Maybe Laura, you could take a crack at that.
We're happy to, and Katie can fill in some details as well. There is a move afoot to take this to the national level, to expand many aspects of epilepsy support, research, and including studies on mortality. This is actually the people within the community have been moving on developing a language to support a national plan for the epilepsies that would, again, be supported by the federal government. We learned today that actually the language is to be introduced very soon into Congress. And the mortality, understanding mortality is a critical piece of that work. Katie.
Yeah, and I was just going to say the purpose of a national plan, and folks may have heard about this in other diseases, but is to really galvanize the power of the federal government in making progress against a disease. And it provides a communication mechanism to really link everything that's happening across the federal government at the different agencies, at different projects, and really a national government-supported push forward. So we're really excited about it. And Laura's right, epilepsy-related mortality was one of, I think, the 6 priorities highlighted as being something that needed to be focused on in this plan.
But this too will require strong advocacy. So if people want to learn more about that, we'd be happy to share that. It's going to take members and people across the nation to share their voices, say how much this is needed to move this forward.
Yeah, this is just the start. This is just introducing the bill, which is a huge step forward, but is nowhere near the end. As everybody knows, we will have a new Congress come January. We will need to reintroduce then and then really push to get this passed. And then that's when the real work starts of putting together the plan and executing a national project. So we're inching forward and we're excited about that.
Very excited.
And so, Katie, just one follow-up to that. There have been other disease states where these types of plans exist. Mm-hmm. Are there 1 or 2 recent models that are particularly interesting for us in the epilepsy community? And Laura, you can jump into if Katie's.
Yeah, I can make it. Parkinson's, I think, is the most recent example. They have been working on their bill for about 2 years. It was signed into law over the summer. So they are just getting started on executing, designing a national plan to be executed. I think Alzheimer's is one where we can look back 30 years and really see what a national plan has done for a disease in terms of funding, in terms of identifying a biomarker. I mean, there have been just huge strides, even with public awareness. Think about how everybody knows about Alzheimer's now. And then I also like to look at ALS, which had its own bill at the end of 2022. It's a much more rare, neurological disease. But their Ice Bucket Challenge, they did a great job making everybody know what is ALS, making the government care about ALS, and really increasing the funding that's going toward ALS research. So there's a lot of great examples to motivate us, and I think to show that this can be done and it can make a difference.
And there are several questions coming in about what can be done at the federal level, and I think this would be a primary example. Would you all say that this is kind of a current point of focus where the issue of epilepsy mortality is a really key component of the proposed national plan. So I think that's front of mind when I think about the federal level. Are there other points, Laura, that come to mind?
Yeah, I just want to share that there are already programs in place that if they were supported further by greater federal funding, it could really make a difference. I referenced that we are collecting information from a handful of states through a program called the Sudden Death in the Young Registry, which is supported by the CDC, Center for Disease Control and Prevention, and the NINDS. And this registry is collecting information about sudden death in the young up to, I think they're moving it up to the age of 24. And it's one of the best ways that we can understand the prevalence of sudden death related to epilepsy. But this is only in 6 states. Across within 6 states, and then some specific jurisdictions within other states. We already have some systems in place that if there was additional funding, we could learn so much more. So expanding on those, and then again, working through federal agencies to provide additional support for physicians who really do need the support to execute, to provide the education that's so desperately needed.
And I would just add, the more coverage that we can get from a Medicare perspective, understanding that that's a specific population, the easier, the work like Hannah is doing in Oklahoma and that we would do state by state becomes. So
I agree with that, Katie, and I appreciate you saying that. I'm currently learning the interplay between Medicaid and Medicare, but I'm also being told that if I can get more states to implement this billing code, that there would be movement on the federal level and vice versa.
they influence each other, absolutely.
Yes, so I appreciate that. Thank you, Katie.
Yeah, of course.
Gardner, we have one of our top advocates from Iowa who gave a question that I think is interesting, which is there any specific information we can send to our state public health departments? Would you want to comment on that one?
Yeah, I mean, I think maybe, Anne, we could show the slide that kind of illustrates the toolkit. Anne put a link to it in the chat, and it's what Katie was referencing, but it's helpful to, I think, see it in the real. So this is parts of what you can find online, and so on the left is sort of the one-pager fact sheet that you can quickly kind of give out to describe an issue. And the other 2 pieces, well, one piece, the one on the far right, is more about what are really the challenges and the barriers and the opportunities around this issue. And then the third piece in the middle is what are the policy solutions that Katie so well described. So we're trying to equip advocates with information to actually take to offices and start having conversations at the state level. And so these sort of detailed pieces, along with personal stories, I think really help to advance these conversations. PAME, I think in adding to this, we hope to kind of update an older advocacy toolkit, which was really the nuts and bolts on like, how do you approach your state legislature? How do you tell your story? Maybe how do you write an op-ed, get attention. Hannah, listening to you talk, I'm like, gosh, how did you even make those meetings happen? And how did you reach out to physician groups to get buy-in? Like all those pieces are really kind of important. So I think there ultimately should be some other scaffolding to this like toolkit, but we're hoping that this can get people going and that we can kind of connect one another over states, like Epilepsy Foundation, Epilepsy-Associated of America. They have amazing networks of advocates like doing this work. And we're hoping to foster more of those connections so we can work together and learn together. But I think the state level piece is just important as the federal level piece. And then there's one more slide actually, Anne, if we can quickly show. and this is just in reference to what Laura was talking about on the federal level and the Epilepsy Action Network that has formed to push this national plan. So people can, right, Laura, click here and sign up for more information and be part of that effort as well.
Yeah, and that's on the PAME website, correct? GardnerPAMEonline.org.
Well, no, this you have to go to the epilepsyactionnetwork.org. Sorry, the little link is buried up there, but you can sign up on there. Laura, is there an easier way? You're muted.
I think
Mary,
that's the right way.
That's the right way. That's the best way.
Great. And just to kind of piggyback off of Gardner's comments about some of the advocacy toolkit steps, there was a person who asked specifically about Hannah and how did you work to advance the billing code? Where did you start? Was that just, a conversation at a time and kind of reaching out to some of your elected officials, or what were some of your initial steps, Hannah?
Sure. Well, I will say I got lucky. One of the first people I discussed this with was somebody who implemented the ESPER code. I don't know if anybody's familiar with that on this, but addiction is, a similar area wherein people were begging physicians to screen for addiction. As in, you have a patient come in your office, you're prescribing them opiates, and you want to do an educational screening. We pay doctors to screen for addiction. And so the ESPER code has actually been really a big deal in that field. And I met somebody who was instrumental in getting that done in Oklahoma. And she said, I see a lot of parallels there. So she introduced me to my state department. As far as getting with elected officials, it's been my experience. They like talking about themselves and their jobs and their work. And so as long as you can kind of get in front of them and say, hey, I've got something that can save lives, and there's a huge national appetite for it. I talk about this group a lot. I say, there are people who have fought for this for 20 years, and there are organizations with a massive appetite for change. And so if you're interested in being in the forefront of really powerful, life-saving change, I've got an idea for you.
That's great. Okay, I think this was covered by Katie, but I'll just bring it back to the front because it is really important. And that is the question: why do accurate reporting numbers matter, and how do we get there? Katie, do you want to kind of put a few high points on that?
Yeah, I think accurate reporting matters because we'll never be able to communicate the burden, the true incidence and burden of SUDEP and other epilepsy-related mortality deaths if we don't have that data. So I think it matters to really communicate that this is not a small problem. This is a big problem, and this is how many families it affects each year. So, I think data is always important. Sorry. So I think data is important to show the problem. And I think all the ways that we get at that data is through more reporting, through classifying the death to be a SUDEP or other epilepsy-related death, to have that being reported on the death certificate, and to have that death certificate being shared with a relevant registry. And I think, I'm not speaking from a personal experience, but having had the privilege of working with so many who have been touched by this, I think it means something to know that your loved one, it's being recognized for what happened, and that you're doing something even with that small bit of data to hopefully drive change so it doesn't happen to another family.
Yeah.
If I might add something there too, I want to say thank you to everyone on this group, because I didn't know, I heard of SUDEP on my brother's death certificate, but it took me 2 years to figure out that it was people on this call, people like me, who are the reason I know about SUDEP at all, right? they'd been begging their state and medical examiners to please list SUDEP as the cause of death. I realized that I only know about SUDEP because of families for 20 years begging for change, begging for help. So as a family that never would have known what killed my brother, I am extremely grateful for mandatory reporting, even outside of the aspects of research, which are so important, but just knowing what your loved one died of, I think everyone deserves to know that.
Yeah, couldn't agree more, Hannah. And I'll say, just as a point of comparing and contrasting, I know in Illinois, we passed a law in 2013 that was meant to improve surveillance around how often SUDEP took place. And the piece that was missing was any type of funding for education. And so I'm really interested in what you're doing in Oklahoma, because I think the reality is that these conversations will happen more regularly if there's a code to reimburse for them. That's just the reality. So I think that's a big advancement in how you're approaching it there, and maybe could be modeled elsewhere. Another comment, just as we just have a few minutes left, I wanted to call out that we do have a breakout at the PAME meeting in December in Los Angeles on this topic. So if you might be attending and you're listening, know that that's on the agenda, and we'll have a little bit more time to dive into this topic, which is clearly very much like at the forefront of our community right now. Are there any closing thoughts or comments that any of our panelists wanted to make before we wrap this up?
I would just add, for people who might be listening, to reach out to us if they're interested, or if they know of interesting models that are kind of in the works at state level. Like, I think sharing of information at the state level is super important. And so as much as PAME can help connect people and point people in the right directions, I think that's the value of this kind of collaborative. So to please kind of lean in on these resources. I don't think any of us have all the answers in one place, but I think we want to support one another in this work and celebrate the models that are gaining traction. So Hannah, I'm so grateful for the work you've done, and I think you're I don't know, just like your whole approach and your willingness to share your very personal story makes a huge difference. So thank you for what you've done.
I really appreciate it. Thank you, guys. And if you guys have any ideas on how best I can move the needle here, if you guys have any ideas on the code language itself, like Laura, especially you, I'm looking at you. If you have any thoughts on the screening code, I'd love to hear them. But I thank you all so much and really appreciate it.
And I'll just make a plug. I know the PAME webinars are all posted in time to the PAME website. So if there are people watching and you think someone else would be interested in this topic, or that they're working on a bill in their state, and you could share this link with them or send them to the PAME website, it would be great for them to hear this conversation and potentially lend their voice to this topic. So, well, thank you everyone for listening. Thank you to our panel for sharing, and hopefully we'll see some of you in Los Angeles. And beyond that, let's keep this conversation going. Thanks for tuning in.
Thanks, Tom. Thanks, everybody.
Thanks, everybody.
Thank you, guys.